Hello guys, this is Indian Medico, and in this video we are going to discuss about the various metabolic keratopathies. First, let's discuss about cystinosis. It is a rare autosomal recessive lysosomal storage disorder. The gene involved in cystinosis is CTNS gene. In cystinosis, there is widespread tissue deposition of cystine crystals leading to pediatric renal failure and other systemic features. There are three forms of cystinosis. The first one is non-nephropathic form, which is also known as ocular form. The second one is nephropathic, and the third one is intermediate form. In case of cystinosis, there can be keratopathy in the first year of life in the form of progressive deposition of crystals in the cornea and conjunctiva. This picture shows cystine crystal deposition in cornea. Clinical features include photophobia, epithelial erosions, and visual impairment. Systemic treatment can be given with cysteamine. Cysteamine eye drop can also be used to reverse corneal crystal formation. Now let us discuss about Mucopolysaccharidoses. They are abbreviated as MPS. They are a group of lysosomal storage disorders involving enzyme dysfunction along pathways for breakdown of glycosaminoglycans. Glycosaminoglycans are long-chain carbohydrates which are also known as mucopolysaccharides. Because of enzyme deficiency, there will be altered metabolites which accumulate intracellularly in various tissues. Most of the mucopolysaccaridosis are autosomal recessive conditions. Systemic features include facial coarseness, skeletal anomalies, heart disease, and learning difficulties. Mucopolysaccharidosis can lead to keratopathy in the form of punctate corneal opacification and diffuse stromal haze, as you can see in this picture. Keratopathy occurs in all mucopolysaccharidosis except Hunter and Sanfilippo disease. Other ocular features of mucopolysaccharidosis include pigmentary retinopathy and optic atrophy. Now let us discuss about Wilson disease. It is also known as hepatolenticular degeneration. It is a rare condition in which there is widespread abnormal deposition of copper in tissues. It occurs due to deficiency of ceruloplasmin, which is a major copper-carrying blood protein. The clinical features of Wilson disease include liver disease, basal ganglia dysfunction, and psychiatric disturbances. Now let us discuss the ocular features of Wilson disease. The key ocular feature of Wilson disease is Kaiser-Fleischer ring, which is seen in 95% of patients with neurological signs. In Kaiser-Fleischer ring, there is brownish yellow zone of fine copper dusting in peripheral decibel membrane, as you can see in this picture. It is best detected on gonioscopy when subtle. The deposits are preferentially distributed in vertical meridian and they disappear with penicillamine therapy. Another ocular feature of Wilson disease is anterior capsular sunflower cataract, which is seen in some patients. Now let us discuss about Lecithin-Cholesterol-AcylTransferase or LCAT deficiency. It is a disorder of lipoprotein metabolism. There are two forms. The first form is complete LCAT deficiency, which is also known as Norum disease. In this case, there is systemic manifestations including renal failure. The second form is partial LCAT deficiency, which is also known as fish eye disease, in which there is only corneal opacification. It is an autosomal recessive condition and the gene involved is LCAT gene. Keratopathy in LCAT deficiency will present as numerous minute grayish dots throughout stroma, which is often concentrated in the periphery in an arcus-like configuration, as you can see in this picture. Now let us discuss about immunoprotein deposition. Immunoprotein deposition in cornea can occur in various conditions like multiple myeloma, Waldenström macroglobulinemia, monoclonal gammopathy of unknown cause, some lymphoproliferative diseases, and leukemia. Corneal involvement can be the earliest manifestation of some of these conditions. There will be bands of punctate flake-like opacities at the level of posterior stroma, as you can see in this picture. We have to treat the underlying disease, and when there is severe corneal involvement, we can plan corneal transplantation. Now let us discuss about Tyrosinaemia type 2. It is also known as oculocutaneous tyrosinemia or Rickner-Hanhart syndrome. It is a very rare autosomal recessive disease and the gene involved is TAT gene. In this case, there is an enzyme deficiency which leads to elevated plasma tyrosine levels. The systemic features include painful palmar and plantar hyperkeratotic lesions, as you can see in this picture. There can also be hyperhidrosis and CNS involvement. Now let us discuss about the ocular features in Tyrosinaemia type 2. Occasionally, ocular involvement can be the presenting feature of Tyrosinaemia type 2. There can be bilateral pseudodendritic keratitis with crystalline edges. It usually begins in childhood and presents as photophobia, watering and redness. Now let us discuss about Fabry disease. It is an X-linked lysosomal storage disorder. In Fabry disease, there is deficiency of alpha-galactosidase A, which leads to accumulation of a glycolipid. The systemic features of Fabry disease include periodic burning pain in extremities and GI tract. The periodic burning pain in extremities is known as acroparesthesia. There can be angiokeratomas, as you can see in this picture, cardiomyopathy and renal disease. Now let us discuss about the ocular manifestations of Fabry disease. There can be white to golden brown corneal opacities in a vortex pattern, as you can see in this picture. It is seen in 75% of cases of Fabry disease and it can be the first feature of disease. There can be wedge or spoke-shaped posterior cataract, which is known as Fabry cataract. There can be conjunctival vascular tortuosity, that is corkscrew vessels, as you can see in this picture. There can also be aneurysm formation and retinal vascular tortuosity. Thank you.